How's it going, guys? Past level question endocrine step one. Before we start, please subscribe my channel. I really appreciate it. Give you a like, really appreciate it. Follow me on Instagram threads, Mehlman_medical, Mehlman_medical, links down below for me on Telegram. Links to Telegram group channel down below. And I start the clip. 28-year-old woman. She has a 3-month history of dull headaches. Blood pressure 180/100. Fundoscopy shows papilledema, absent venous pulsations. Abdominal examination shows costovertebral angle bruise. Question wants to know which of the following is most likely to be seen in this patient. So you need to know that papilledema, blurring of the optic disc, and absent venous pulsations are two high-yield findings for increased intracranial pressure, okay? And the costovertebral angle bruise, this just means over the kidney. And we have a 28-year-old woman, so diagnosis is past level fibromuscular dysplasia, okay? It's going to be tunica media hyperplasia / dysplasia, okay? It's not actually dysplasia, but despite the name, okay? But fibromuscular hyperplasia, they can describe it as, or just fibromuscular dysplasia. And if you had a 68-year-old woman instead with diabetes, hypertension, smoking, then that would be renal artery stenosis due to atherosclerosis, okay? So this has nothing, fibromuscular dysplasia, FMD, has nothing to do with atherosclerosis. You need to know those two distinctions. So we would not say this woman has renal artery stenosis. We would say she just has fibromuscular dysplasia. If you say renal artery stenosis, it implies atherosclerosis in an older patient with cardiovascular risk factors. Now that I prefaced enough, let's just hop to the answer choice here. What's most likely to be seen in this patient? Choice A, decreased filtration fraction, instantaneously wrong. And we know that's wrong because we're going to have increased renin-angiotensin-aldosterone system here. So decreased renal perfusion means that RAS will be upregulated, right? So juxtaglomerular cell activity will be increased. B is fucking wrong. So juxtaglomerular cells are going to secrete renin. Renin lead to increased angiotensinogen cleavage in angiotensin 1, angiotensin 1 cleavage in angiotensin 2, and then angiotensin 2, among its numerous effects, one of them going to be constriction of the efferent arterioles leaving the kidney, increasing filtration fraction, which is GFR over renal blood / plasma flow. So if we have decreased renal perfusion, but we have constriction of the efferent leaving the kidney, we cause a backup at the glomerulus where GFR doesn't increase. It's merely that GFR will now stay the same divided by decreased renal blood / plasma flow, and that means our filtration fraction is increased. Wrong fucking answer. Choice B, as I already said, wrong fucking answer, because JGA activity, juxtaglomerular apparatus, will be stimulated, not suppressed in the setting of decreased renal blood flow. Okay, so renin activity clearly going to be elevated here. Wrong fucking answer. Choice C, decreased serum bicarbonate, wrong fucking answer. So this would imply that we have decreased aldosterone, not increased aldosterone. Aldosterone clearly high here. So what aldosterone is going to do, two main things in the kidney. One, it's going to upregulate sodium potassium ATPase pumps, basolateral membrane, cortical collecting duct, and late DCT. And that's going to lead to increased sodium retention, increased potassium secretion, increased proton secretion. So what I want you to know is an easy way to remember things is the arrows are going to go the same way as aldosterone, the same direction as aldosterone. Potassium goes the opposite. So for example, you say aldosterone is high here. That means we have an up arrow for sodium, up arrow for bicarbonate, up arrow for pH in the serum. Potassium's the opposite, down arrow for potassium in the serum. Wrong fucking answer. Choice D, increased adrenal medullary stimulation, wrong fucking answer, because aldosterone is secreted from the zona glomerulosa of the adrenal cortex, not the medulla, okay? So it's not dramatic, it's past level. The medulla in the adrenal gland is going to secrete the catecholamines, norepinephrine, epinephrine. That's the site of our pheochromocytoma tumor that secretes the catecholamines, right? But if we're talking about aldosterone secretion, zona glomerulosa of the adrenal cortex, zona fascicularis secreting cortisol, zona reticularis secreting the androgens, DHEAS, androstenedione. So we would have increased adrenal cortical stimulation, but not medullary stimulation. Wrong fucking answer. Choice C, Kali-Uris is correct answer. You simply need to know that that means increased potassium micturition. It's not dramatic. You got to learn some vocabulary, okay? This isn't meant to be a gotcha question. It's if you know your endocrine, you can eliminate to get there. Not dramatic, okay? So as I said, when aldosterone is high, you're going to be secreting potassium into the urine. Secretion means excretion through the wall of a tubular cell. So if you say excretion alone, that's too general. That means you say, well, is it filtration? Is it secretion? So we have aldosterone secreting potassium into the urine via the upregulation of the basolateral sodium-potassium ATPase pump, as I already talked about. It's going to be reabsorbing sodium, and it's going to be secreting potassium. And then it's also, aldosterone will also upregulate an apical proton ATPase, directly secreting protons into the urine in the cortical collecting duct, okay? So that's why when aldosterone is high, the arrows go the same direction, potassium the opposite. So we have up arrow, serum sodium, up arrow, serum bicarbonate, up arrow, serum pH, down arrow, serum potassium, because we're secreting it into the urine, increased potassium micturition, aka kaliuresis. You know the deal. To make more content, if you like my stuff, subscribe my channel. I appreciate your time. That's it.